Do you see my screen? Yes, no.
Yes, yes.
Okay, all right. So this is the scout image. When we do CT scan of the patient, CT chest, we put the patient in the scanner, and when we scout to see where things are first, and then we start scanning. So you can see the scout image. We have a very big heart here. It's more than 50% of cardiothoracic ratio. So this is big heart. And this could be just cardiomyopathy, dilated cardiomyopathy, or heart chambers are big, or it have pericardial effusion. Look at this CT scan. This is coronal reformatted image of this person. You see, this is my heart. The whole thing is the heart, and this is the fluid. So the patient has pericardial fluid. This is simple pericardial fluid on coronal image, and on sagittal reformat image. You see the fluid is here. When the patient in the CT scanner, they lie down. So the fluid, free fluid, will move to the posterior part of the pericardial cavity, here. So that's why it's piled up in the back. And this is on the axial. You see that? This is the heart, and this is the fluid. So seeing big heart on chest radiograph may be dilated cardiomyopathy, very bad valvular mitral valve disease, or maybe pericardial effusion. You don't know. You don't know just by the imaging. You probably know by the clinical context, but not by the imaging. Okay, so now today we're gonna talk about chest radiographs and CT chest correlation, and we will look at the common pathology. Okay. The standard chest radiograph will be PA or AP, and actually the original standard is the PA. Means that the beam is coming from the back, from the posterior to the front to the anterior chest. So this is how it looks like on the PA chest radiograph. We saw this yesterday. And look at our CT. When we do the scan, we scan the patient on axial images, and then we use the software to reconstruct those axial images into sagittal and coronal. So I'm showing you coronal reformatted images of the chest CT. Okay, so we'll start from the top. I'm gonna stop it. So see that you start seeing something weird here on the top. When you go a little bit further, see that is the little air pocket, two air pocket. And then when you go a little bit further, this is the face of the patient. So this is the maxillary sinus. You are responsible for everything in the study. So this is the maxillary sinus. You start seeing mandible here, and then after that we start seeing the breast soft tissue. So this is a female patient, and it's a young patient, very dense breast soft tissue here. And then we go further, we start seeing bone. So this is my sternum. Normally we don't see sternum on chest radiograph, but we see it very clear on CT. And this is my sternum. This is xiphoid process. I'm going a little bit further. You see manubrium here. So it has, manubrium is right here. Okay, I'm gonna go further. And this is my clavicle. You see two clavicular head attached a little bit with the manubrium right there. That's forming cartilaginous joint here. And I'm going a little bit further. Okay, that is still my clavicle and ribs here. Look at the ribs. Yesterday I showed you one thing. I said that the ribs has two parts. The anterior part that is attaching to the sternum and manubrium, or the xiphoid process here. This is cartilage. Normally cartilage, we don't see it. It's really loosened. So on the chest radiograph, you don't see it until it has calcification in an elderly. You will see that. So this is the cartilage or anterior aspect of the ribs. Okay, I'm gonna go further. We start seeing a spine. So this is my thoracic spine here, and then this one is the spinous process. This little guy is the spinous process, and it's from the joint with the ribs in the posterior rib. So from the joint. Okay, so I think we are, and you see your scapula here, and your let me go, glenoid fossa, and then the humeral head, right and left are the same. Okay, and you see all of these rotator, the scapular muscle, rotator cuff muscle here as well. Okay, so we're done with the soft tissue and the bone. Now we're gonna go further into the chest. We're gonna go see that the contrast. We inject this is CT chest with contrast. So you start seeing bright contrast in the vascular structures and the heart here. We injected the contrast from the right upper extremity, and the contrast coming through here. So it's going into the subclavian vein, and then the right there. Okay, this is the subclavian vein, and then this subclavian vein will join the right internal jugular vein. You see that this is the right internal jugular vein. Subclavian vein, it will become the brachiocephalic vein on the right. Pretty short. Okay, and then if you go a little bit further, so this is the brachiocephalic vein on the left. And the is coming from this brachiocephalic vein is coming from left internal jugular and left subclavian, and it's from the left brachiocephalic. Now left and right brachiocephalic vein is joining and then becomes a superior vena cava. This is superior vena cava, and it is entering the right atrium. This is my right atrium, and from right atrium, this is the tricuspid valve. It will go into the right ventricle. This is my right ventricle. That's why right ventricle is around here on the chest radiograph. From right ventricle, it will go into the pulmonary artery. This is my pulmonary artery. It's going up to the pulmonary artery. Name is artery, but actually is deoxygenated blood because it's accepting the blood from the head and from below. I will go to that later for the below. So this is the pulmonary artery. Pulmonary artery going out. This is main pulmonary artery. It divides into the right pulmonary artery and left pulmonary artery. So this part is the hilum. You can see this is my left hilum here on chest radiograph. It has pulmonary artery, a little pulmonary vein, and airways and lymphatic system that is forming the left hilum. The right hilum is the same way. Okay, so after that, going out and have gas exchange in the lung. After that, it becomes oxygenated blood and coming into the pulmonary vein. So this is my pulmonary vein is draining back into the left atrium. And this is your left atrium here. This is left atrium. And left atrium is going into left ventricle. This is my left ventricle. I'm going to show you a bit better here. So this is my left ventricle. This is my mitral valve. From left ventricle, it will go out into the left ventricular outflow tract. This is left ventricular outflow tract here, and this is the aortic valve, and this is the ascending aorta. So from the ascending aorta is feeding our body. So at the aortic arch, there are three branches. The first branch here is the right innominate. And right innominate will divide into the right common carotid, this one, and right subclavian artery, this one. Okay, that is the first branch. So the second branch is left common carotid, which is this guy. If you follow me, you can see left common carotid is going up here and very close to the thyroid gland. Up here. This is my thyroid gland. This is the airway. We talk about the airways later. This is thyroid gland. That's normal thyroid. Normally, thyroid gland, the function is trapping iodine from food or from anything that's coming into the body. So this contrast media is iodinated contrast. So the thyroid gland will trap a lot of that contrast. So this is the left common carotid, which is the second branch from the aortic arch. And the last branch of the aortic arch is the left subclavian, this one. Okay, and if you'll see that it's curved a little bit, become left subclavian artery and going into the upper extremity. Okay, and let's look at the belly a little bit. So this is your liver. This person have a very well expanded liver. Normally, sometimes the liver, the left lobe stop here, right below the heart. Sometimes it's cross the midline and cover the spleen. Like this one is covering the spleen. Okay, this is the portal vein in the liver. The liver has dual blood supply. This is the portal vein. This is the main and the left and the right portal vein. The liver looks good. And then you see, this is my descending aorta. Descending aorta coming down, supply the belly. Okay, this is my spleen right here. And this is the stomach with the fluid. And we also have a little bit of left kidney and right kidney. You can see it here. This is my right kidney and left kidney. And that is, we can't see those structure because it all blend together in the on chest radiograph. And I think we see, let me look at this. Okay, that is our chest radiograph compared to the CT. CT has way more detail than chest radiograph that you can see. Okay, that is frontal. And normally when we do sagittal, not sagittal, we call it lateral projection. So we it's a standard chest, so we have lateral projection as well. Okay, let's compare this structure. So this is reconstructed images on sagittal image compared to lateral chest radiograph from the beginning. Start seeing the humeral head. All right, so we're gonna start now. All right, this is the famous doctor. And then he is a medical illustrator. We all know about him. This is the Dr. Frank muscle. And you see a little lipoma. This is fat. Look at the fat density on CT, super dark. This is a fat in the muscle. There is a small lipoma. And we go further. Here. So this is our chest scapula in the thorax here. This is our trachea. You see trachea will have like a cartilage. This is on the bone is cartilage right, because the and posterior of the trachea have no cartilage. It's just membrane. So and this is the liver. So one ring to the next ring of trachea, and this is the breast soft tissue of the patient here, all the way down. And then when you come are about to bifurcate, and let's look into the right and left main bronchus. We call this area carina. Okay. This is the trachea carina, and then left main, right main bronchus, a little bit, and left main bronchus here, and we have the heart in the middle, and the heart. This is my left, my right ventricle, right here, a little bit of epicardial fat here. This is the right ventricle. Contrast. The structure that's come out of the right ventricle is the pulmonary artery. This is the confusing name. The name is artery. So it's from the top and from below. It carries the oxygenated blood from the right atrium, from the whole body. It's going to come to the passing through the right atrium, to the SVC, IVC. This is a right ventricle. Enter the compared to chest radiograph, right ventricle will be pass through the tricuspid valve to the right ventricle, and now they're out of the pulmonary artery. We call it pulmonary artery, but it is deoxygenated blood. After that, it have a gas exchange in the lung parenchyma here, and then it's come back into the pulmonary vein, which is the red color. The red is oxygenated blood. So the pulmonary vein will drain into the left atrium, coming back, and then after that, passing through the mitral vein. This is my left atrium, and coming out here. So left atrium has this is our ascending aorta. This is our aortic arch. This is a pulmonary aorta. So when we talk, you heard about, you hear about the word hilum. Hilum, I'm showing you, always say that. So hilum on chest radiograph, we are talking about four structures. Left atrium is around the airways here, there are pulmonary artery here, and pulmonary vein. They're all like right here. So this is also lymphatic system. From the left atrium is everywhere. So they all pile up here. This is the right hilum, and this is the left hilum. And you see these line here. So this is the fissure of the lung. This is left ventricle. So the left ventricle shadow on chest radiograph is and this is our fissure that separates the upper lobe from the middle lobe and lower lobe. This one is the upper lobe, and this one would be the middle lobe. The middle lobe is here, and then this one is the lower lobe. We show you on CT
And
tomorrow.
this is the ascending
Okay, for the
aorta.
left lung, we have two
Compared
lobes.
to the chest
This is the
radiograph, the
upper
aorta
lobe,
is
and this is
here.
the fissure again, oblique
And then
fissure, and this is
curving
the
up to
lower
the
lobe.
aortic arch. Aortic arch is
Okay,
here on
do
chest
look at the
radiograph.
anatomy of the
CT,
vessels a
aortic
little
arch
bit.
is here.
So we have
and then descending aorta
axillary
is coming down here.
vein
So descending
coming
aorta is here
into
on, like on
subclavian
top of the
vein,
spine.
and then
And again, you
join
can follow three
IJ,
branches of the aortic
internal
arch.
jugular
This is a
vein
right
on the
innominate.
left, and then it will
And
become
then
left
brachiocephalic
common
vein.
carotid. Left brachiocephalic vein,
And
is
then
this cord
left
is coming
subclavian.
across the
So all
midline
three
and
are
stop
here.
here. So now it will
For the
join the
belly,
right brachiocephalic vein.
it's the same.
Which is
So we
the,
see kidney on
internal
the
jugular vein
we
on
see
the
liver,
right, and then internal
we see
jugular
the
vein
heart.
will
So
join
this
the
is on the
subclavian
right.
vein.
Sorry, on
and
the
become
left. On the left.
brachiocephalic
So
vein.
this is
So
our kidney,
brachiocephalic
and this is
vein
our
on
spleen
the
has
right
different
and on the
enhancement
left
from the liver.
join at around here
And,
become the proximal SVC.
this is the,
and the SVC
right
will
kidney
come
because
down,
it's
down,
below
and
the
then
liver.
enter the right atrium,
Okay.
going to the
And
heart. Okay,
I think we are done with the
I'm not going to
coronal
go
CT.
to talk
Now
about the
we're going to
lower
look at
extremity.
the
They are the
raw
same
data.
fashion, but today we're going to focus on the
We
chest
scan
only.
on axial, and we use axial images to do reconstruction. So you are seeing the thing that's already manipulated by the software. But this is the real raw data that we get at the beginning.
Why
But I don't have comparison to compare to, because the chest X-ray that we do normally we do sagittal and sorry we do PA and lateral.
I don't understand why
Let's look
I
at this
have
on
these,
just normal anatomy here. So from the top, trachea, we will talk about airways later, but now let's focus on the soft tissue.
Okay, next one.
This is
Okay,
the very
we're gonna
dense,
compare
high
this
density structure here close to the
anatomy
neck.
with the
So
chest
this is the
radiograph.
thyroid
Okay,
gland
all
here.
right. Here's
Looks
the
normal,
fun part
very
of it.
nice homogeneous
Okay,
enhancement.
this is our like
And
a
then
nice
we
perfect
going
chest
down.
radiograph
Let's
here.
as we
Okay, I'm
talked
gonna
earlier,
start.
we inject
We
the
are gonna
contrast from the
look at
right,
that.
so
You
the
had,
contrast is
I'm going
coming
back
in.
here. You see, this is the air
Coming
column,
in, and
so
then
this is
become the
corresponding
right
to this
subclavian.
image. So this is a trachea and trachea.
From right
And after that, we
subclavian,
talk about this.
the
So
right
a bifurcation of the trachea into the right and left main
internal
bronchus.
jugular,
This is the carina.
enjoy
So
that
the
right subclavian
orange color is
become the,
carina. And then after that, it will divide into the
sorry,
right main
I like to
bronchus
use that
and
word,
then to the
brachiocephalic
left main bronchus.
on the right.
You
So
see
this
this
is the
little air
brachiocephalic
column
on the
here,
right.
the lucency
And then
here.
you go
So
down a
this is
little bit
the air
further.
column
This
of
one
the
is the
left
left
main bronchus.
brachiocephalic.
And
if
this
you
one
follow
is the
the
clavicle.
left brachiocephalic,
I
you
don't
can
have
see
the
that it's
illustration
from the
to show,
left
but this is the
subclavian.
clavicle. This is the clavicular head here. So the clavicular
Don't
head
see a lot of contrast, but this is the left
formed
subclavian.
a cartilaginous
from
joint
the left
with the manubrium, which is
internal
somewhere
jugular
around
up
here. Normally it's really
So,
loosened
become
because it's
the
not a lot of compact
right
bone,
and left,
so we can't see.
brachiocephalic.
And next, this is the
Vein become the proximal SVC, and then this is my SVC.
I know what happened. Whenever people join in,
SVC.
that will happen again.
SVC.
Okay.
This
And
guy.
I cannot
And then
forward.
SVC is draining into the
I have
right
to
atrium.
stop
Okay, this is
allowing
my right
people to
atrium.
join because it's
This thing is
interfere
the right
the
atrium.
flow.
From the right
here.
atrium.
Okay. So
This is
here,
the right atrium.
this is
Right
the
atrium passing
transverse
through the
process of
tricuspid
T1.
valve going to the right ventricle.
And then this
you can see
bone
that
is the
how
first
close the
rib.
right ventricle to the
And
sternum.
the first rib will have the
After
cartilage
that is
anteriorly,
right
and this
ventricle,
cartilage
right
will
ventricle
attach
will
to
go
the
out
manubrium.
to the lung.
So this is the cartilage of the first rib. You don't
Become
see
the,
cartilage does not have
pulmonary artery.
density. It's so loose and you can't see it. If that cartilage calcifies,
This is a
see
pulmonary
it.
artery.
So
It's
this
coming
is my
out
scapula,
from the right ventricle,
and
going to the
scapula
pulmonary
tip
artery.
here. The
Become
spine is
the right
here.
main.
And then this is
right main
my
pulmonary
vertebral
artery
body. You see
and
this, the
left main
T-spine
pulmonary
here.
artery here.
Okay, this is
And
my
then
T-spine.
after
I'm going
gas
back
exchange,
and look at
become oxygenated
another
blood.
thing here.
Will come
Look
back
at this
into
little
the
cute
pulmonary
thing here.
vein. This is a
So
pulmonary
let me
vein.
go back here. So
Here
this is my
is draining
T-spine,
into the
mid
left
T-spine,
atrium. This
and
is the
this is
left
like
atrium.
a big
See that
eye,
how
a
left
big eye
relationship
on the
of the
right,
left atrium and the spine
on the right
is
of
very
the
close to
T-spine
the
here.
spine.
That is the pedicle.
And then after
Pedicle
that,
of the spine.
left
It used to be very
atrium,
important in the
passing through
past
the
because
mitral
when
valve going to the
tumor
left
is
ventricle.
eating bone,
This
the
is the left
pedicle will
ventricle.
go first.
From the left ventricle,
the
is
first thing we
squeezed
look
blood
for is
out
we
to
cannot see
supply the
pedicles,
body.
mean the tumor is
So
already
it's
eating
coming
up that
out.
piece
This
of
is
the
the
bone.
left ventricular
And this is
outflow
the
tract. Going to
transverse
the aorta,
spinous
this is
process
my
of the
aorta.
spine. Okay. And
After that,
what
become
about this
the
structure?
aortic arch.
You know,
I am
coming
not
up
a
here.
native
This
speaker,
is the aortic
and I have
arch,
a lot of
and
Asian
then
accent.
coming
But my
down
residents
become the
under
descending
my
aorta.
residents, they
So
understand
we have
me.
all
So the
vessel
language is just for
complete. So
communication.
this is the three branches
Whatever
of the
accent
aortic
you are
arch.
is okay.
Right innominate,
It's
left common
okay. I
carotid,
still
and
have
left
very
subclavian
thick
artery.
accent.
So this is
doesn't
our
matter. Please speak up.
brief
And I don't see your
anatomy of
face. We
vascular
don't know who
anatomy
you are.
of the lung
Okay,
here.
you can
And
speak
then,
up.
you
So
saw
what
also
structure
we
is
look for
this
something else.
compared
So
to
this
the
person is a young
illustration?
person. The bone doesn't look so bad.
Anyone,
and she
you
has a
can
very
shout
dense
out loud.
breast soft tissue. The left breast
Maybe
look a bit
aortic arch
denser.
or
I'm
aortic
not
node.
sure why.
Okay,
if it
that
is
is
young
correct. So
patients,
this is one is our aorta, right?
We probably
so this
leave
is
it
the aortic
alone.
knob. Okay, next structure.
Because we
Next
don't
structure.
do normally
Good job.
mammogram
Good
when
job.
we start doing for like
Okay,
a
what
breast
about
cancer,
that?
we start at 40 years old. She's for sure younger than 40 years
This
old.
structure is important.
And that soft tissue, that bone.
I would say,
apologize.
should
I
I-
don't have
should I
bone
call it
window for you.
structure?
But let's look
Probably
at the
should not
belly a
call it
little bit.
structure because
This
there's,
is my liver.
There's little structure in
The
there.
liver is so
Very
big. I mean,
important.
it's so long,
When the
not
patient
big.
come
Across
in,
the midline,
present to us
the
with
liver shape
hoarseness.
has a lot of variation. Sometimes
it's
it's so
something
short,
wrong with the
sometimes it's so
vocal
long.
cord.
So
And
across
that
the
is the
midline
key
here,
thing
and
that we
even
need to
is
look at.
wrapping around
Who know what that is?
the spleen. See that?
So
This is all this
Yes.
liver enhancement is different. This is the spleen, part of the spleen.
Pulmonary
The spleen
tongue.
was wrapping,
Okay,
is wrapping,
almost
is wrapped
very
by
close,
the liver.
very close.
Okay,
So
this
this
is
is
my
the
portal
pulmonary
vein.
vein. This one.
This
This one
the
is the
portal vein.
hilum that
Okay,
we like
this
to
is the
talk about,
IVC,
but this is above the
intrahepatic
hilum.
IVC. If you follow me,
And then
if you
below
follow
the
me, look at
aortic
this
arch.
guy, it will drain into the right atrium.
Above
See
the
that?
hilum,
See
below
that?
the aortic arch is
SVC,
this
IVC
space.
draining into the right atrium.
This one,
Okay, this
this
is the
space.
spleen. This is the stomach.
So what we
and
what
then
should you
we
what
still
should we
have,
call it?
this is the
actually
pancreas.
is anatomy. So this is
the pancreas.
aortopulmonary
Very
window.
nice, juicy pancreas.
Right.
And
so
this
is
is
the space, an
gallbladder.
empty space between
See a little bit, don't see the whole
aorta
thing,
and
still
left
look okay. This is the
proximal left
kidney.
main
So
pulmonary
she has,
artery. So this, or you may
and
hear
she has
people
a
say
renal
AP
cyst
window, AP
here.
window. This is what we're talking
And,
about, AP window. Okay,
Look
why
at the
AP
vascular
window
again.
is
So for the
important?
vascular,
What
this is the
structure
abdominal
is lying
aorta.
in there?
This is the celiac trunk.
Bronchus.
Celiac trunk is supplying the liver.
Oh yes, bronchus
And
is
the
right here.
spleen
This is my
and the stomach.
airways. So,
So this is my
bronchus.
celiac trunk, and this is
Okay,
superior
so we talk
mesenteric
about
artery.
the hoarseness. People
This
who
is
came
the
in with
splenic
hoarseness,
vein.
like head and neck cancer, and has
Okay.
hoarseness.
All right, that
And
is
then when we scan the
raw
patient,
data
we don't
from
stop
the
at
axial
the neck.
scan
We
of
go
CT
down up
anatomy.
to the
And,
hilum.
let's do
to be able to
airways and
see this
fissure.
space.
So
because
from
this
that,
space has
I put
recurrent laryngeal nerve.
I have a
It's
sagittal
hanging up.
and
It's coming
coronal
down, the
of
vagus
the
nerve
airways.
coming down.
So this
and
is
then
the lung window.
taking off a branch
You
and
can
then
see that
curving up.
it's
That's
look
why we
different
call it
from
recurrent
the one
laryngeal.
before. This is
curving
exactly
up
the
and
same
then feed
patient,
the
but I just
vocal
changed
cord.
the window.
If there is a
from
mass,
soft
big
tissue
mass
window
here,
to lung window.
or like
So
a
this is
hilar
my
mass, and
right
pushing
lung.
the recurrent laryngeal
Okay.
nerve, the patient will come
Don't
with
mind
hoarseness.
that. Okay.
Because
this
the
is
patient
my
will have
right
vocal
lung.
cord
So we have
paralysis
the
on
right
left.
upper lobe.
Okay, that is a very
And,
good, very
right
important
middle lobe and right
landmark
lower
for
lobe.
recurrent
See, there are
laryngeal
two
nerve on the
fissures
left.
on the
What about
in the
recurrent
right
laryngeal
lung.
nerve on the right?
So this is
where it
this
goes.
picture. This one is we see it better. Let me show you here.
Okay,
and then we come
alright.
back to that.
I have an illustration
So this
later
is the
to show
right
you
lung.
where it goes, but for now we're gonna move on.
Let
So
me
this is AP
stop this.
window,
So there are three
aortopulmonary
lobes in the
window
lung.
between the
This
aortic
is
arch
the
and
major
left main
fissure.
bronchus. Sorry, left
This is
hilum,
the minor fissure.
or left main pulmonary artery.
This
not,
is the upper lobe.
bronchus. They're all
This
hilum.
is the
We
middle
should call it
lobe,
hilum
and the
because
whole
it's a
thing
hilar
is the
structure.
lower lobe.
Okay,
here.
this is our
Okay. For
left hilum
sorry.
and our
And,
right hilum,
for
as we
the,
talked earlier.
for
so
this,
hilum,
axial,
like
for
four
this
structures
coronal,
in there. There's a airways, there are pulmonary artery, pulmonary vein, and
It's
lymphatic
probably the
system.
best.
They're all together. That
one here, upper
made
lobe,
up
middle
hilum.
lobe, and lower
And
lobe.
then what is this
Okay.
part
And then
of the
for the lateral
cardiac shadow here? So
sagittal
this is our heart.
image
our
of
heart here. So what is
left
this?
lung. Left lung has
What
two
chamber
lobes.
is that?
This is the fissure.
long fissure. So the whole thing is the
Right
upper
atrium.
lobe, and these parts,
Okay, it's a right atrium. You
below
can
the
see
fissure
this,
is the
right?
lower lobe.
So this is
This
the
is
right
the
atrium.
where we
So
talked yesterday
the right
about
atrium
this.
is
This
only
is the
this
posterior
chamber. If you
costal phoenix
if you see
sulcus.
double shadow,
How
like
nice and
something
sharp it
hiding in
looks.
here,
And this
that
is
may be
lateral
left atrium
costal
in the
phoenix
back, so
sulcus,
you can
nice
see
and
two
sharp
shadows.
looking.
If you see
So
that,
look at
it
the
means that
airways.
left atrial enlargement.
This is a
But this
trachea.
one is a normal chest
In the
radiograph. This is a
midline,
right
when it's
atrium.
coming
Yes,
down,
that's good.
it's bifurcate.
Okay. What
So
about
this,
this
we call this
shadow?
part
What is
carina.
that?
And then from that,
Left
it
ventricle.
has the
It's a left
this is the
ventricle.
left main
Yes.
bronchus.
Do we
Very
see
short.
on
After
chest
that,
radiograph
it's
we
take
will not
off,
see right
become the
ventricle
right
because
upper
right
bronchus.
ventricle
This
is
is one.
against the
And then
sternum is right here.
the
and you
rest of the
cannot see
airways will
border
come
from
bronchus
here. It's somewhere
intermedius.
here, but you at the
From
border
bronchus
of the heart is
intermedius,
not.
it will divide
So this is a
into
left
the
ventricle.
lower lobe.
Sometimes you can see like
and middle
a
lobe.
left ventricular
This one is right
aneurysm
middle
because
lobe
the heart is
bronchus.
just so big.
And this
Okay,
one is
what
the
is
right
this is
lower
the,
lobe
we
bronchus.
like to talk about this. This is the
So,
location for
the
the
left
pericardial
lung
cyst.
has a very
And when the
long
patient has mass here, right
left
here.
main bronchus.
So this is the
From the left main bronchus,
cardiophrenic
it will
angle.
divide it into two lobes.
Cardio heart. Phrenic
Left upper
is
lobe
the diaphragm.
bronchus
So
and
it's
left lower lobe
cardiophrenic angle
bronchus.
on the right and on the left. Very good
All
and
right,
common
so we are
location
done with the
for pericardial
airways. We are
cyst,
done with the
which
soft
is a
tissue.
benign
We have a
lesion.
little peek.
And then
of
what
the
about
bone.
this? What you
So
call
now
it
we're gonna
by
look
anatomy?
for this anatomy. I'm gonna ask you, what is
Can
this
can
structure?
Okay,
I'm gonna
so
point
we
it out
call
here.
this
This structure
we
right
call it
here. I show
sulcus.
you on the CT.
We call it
What is
sulcus,
that?
but the name will
Okay,
change.
this is a normal
This
chest
is
radiograph. First thing first,
costophrenic
very
sulcus.
good penetration, good exposure.
Here.
So this is the
costo
tracheal
is
air column.
the rib.
This is
and
my
phrenic is the
left
left
main
So it's
bronchus.
costophrenic
Can't see
sulcus.
much
So
of
this
the
is
left right main bronchus here.
The lateral
structure that I am
sulcus.
asking you
And then we
is
also
this
have the
little
posterior
bump
phrenic sulcus.
between
And JP, my
tracheobronchial
colleague, will give
tree.
you
This is
a session how to
trachea.
read chest
This is the
radiograph
right upper lobe
on
bronchus.
PA and
It's
lateral.
sitting
We're not
right
going to
here
go there
at the
here.
right tracheobronchial
So
tree.
costophrenic sulcus is important
Anyone
because
know
it
what
has to look
structure
nice
is
and
that?
sharp.
We always
like
have a
that, very
problem when
pointed
we put
tip
the
here. One is has
peripherally
is
inserted
This
central
means
venous
you have
catheter,
something in there.
or here
Either
we call it PICC.
most common
in
can
the
be pleural
patient.
fluid.
Sometimes the tip of the
It
PIC
can be blood
is
as well, or the patient have
going
pleural
toward,
fat,
not going
or
toward,
have
just sit
pleural
in that
thickening,
structure.
or even have a mass or pneumonia there.
I think it's
So it should be
the
nice and sharp
exobronchial
looking
lymph
like
node.
this. Okay, good thought. Okay, what else it
Before
can
we
be?
go,
What
if
is
you
that?
put things together, I'm
The
saying
yellow
that
one?
we always has the problem with the
Catheter.
PIC placement. Peripherally inserted central venous catheter.
Internal thoracic opening.
So when I say that it is
On the
intravenous
system.
structure, right?
I'm trying to
The lymph node is
I'm
something
trying to
outside
point
the
out to
vein.
this structure.
It's in the
So
soft
what is
tissue.
that?
So what else can be here?
SGC.
Is that
Superior
normal?
Okay. So let me go back to anatomy again.
When we read chest radiograph, you are responsible for everything.
So I'm
everything.
talking about this structure
think
right
it
here
is
at the
so much air.
tracheobronchial tree. Let's look.
Yes. So that's good. That is correct. So this is the air in the stomach. You can see
All right.
that
Do you
because
see
the
this
stomach is
structure?
just
Let me
right
stop
against the
I'm
diaphragm,
talking about this
and then you can
structure.
see that
This guy.
there is
There's a
air fluid
problem
level.
when
we can
people
tell
put
this
this PIC
person
in,
is in
it's
upright
just
position.
plug in there, like
Because
just
you
sit
see
there.
air fluid
That
level.
structure that
The
I'm talking
stomach
about.
is filled with
Is
air
it superior
and
vena
fluid
cava,
here,
I think?
and
My
the
superior vena
space
cava
between stomach,
is
air in the
That's
stomach. And
is
the
here.
diaphragm should
So
be less than
this
1
structure
centimeter.
we are
If that
talking
is thicker than 1
talking
centimeter,
about this
that may be
structure,
called
which is this
subpulmonary
guy.
effusion.
All
Subpulmonary
right,
effusion
so,
is mean
let
pleural
me
effusion
show
that
you
is
on
very,
lateral,
very
on
linear
sagittal.
and confined to the diaphragm.
You will be
Nice
able to
looking.
tell me if I show you
So
the
that's we call it
anatomy.
subpulmonary effusion.
Okay, so
the
it
space here, not the
is
space, the
this
thickness
structure.
between
Okay,
air and diaphragm
stop.
should be less than 1 centimeter. Okay, next structure. What is that?
This guy is draining into the superior vena
colon,
cava.
transverse colon.
Air in transverse
Ozagal.
colon.
Ozagal friend.
It's not air in the small
Like
bowel.
this
You think?
Ascites, that's good. See that?
Can
have
it
to
be
tell you
jejunal
anything.
loop?
You just have to look at anatomy. So it is the
Can we tell?
azygous vein. It's always sitting at the tracheobronchial tree.
If I'm going to say
Sometimes it
in
can
the
look like
jejunal loop, anyone
maybe
have
like
any
you're right.
argument about that?
If just by anatomy, it can be a lymph node easily. And
transverse
when we
colon.
put the PICC line, sometimes the PICC line we don't want it to go
Why
there.
you think it's colon?
What
Why it's not
we want
jejunum?
is the
Why it's
tip
not
is in the
ileum?
SVC or atrocleval junction, but sometimes it just got right in there somehow. And look at this.
I know it's
I'm
stupid
talking about this
question,
guy,
but
this
if you
little
can
guy
explain
here,
it to me, it means that
and
we
also
understand
this
the
one.
anatomy.
See that? The filling defect in here is because
Why
of
it's
the
not
flow
jejunum
artifact.
or
It's not because of thrombus.
ileum?
It's a flow
Ileal
artifact.
loops.
This one is superior vena cava, and this one is about to be the right atrium.
Blocked by
This is
transverse colon.
azygous vein.
This is
Good.
blocked by- Jejunum is
Okay,
blocked by
next
transverse
one.
colon.
Okay. Okay. There are
Okay.
two
There
a few reasons.
what is this
Location.
structure? I know it's just
What you're talking about,
jejunum,
this
it
should
should
be
be
aortic
down
arch.
here.
So
in
it's not
the,
aortic
deeper
arch. It's
down,
something close
lower
to the
than
aortic
this.
arch.
And two, this is you see hostration.
Normally,
of the colon.
look
The
at this,
jejunum loop have
again.
valvula
Let me look
confinentis. So the folds and
we see
the
it here
folds is
too.
different.
This is
we
my,
don't see the
I'm not
diameter.
sure this is
the
my
diameter of the
aorta,
colon
a
for
little
sure
bump
is bigger
here.
than
I'm talking
jejunum.
about a
Number
little
one,
bump.
the reason why it is colon because the
I'm
location.
talking about little bump
Close to the location in the
arch.
abdomen, and also we see this little thing here. Hostra. A large
Right
valve,
there.
the colon has hostra, but
Dimple.
the jejunal
A
loop
little
have
dimple
a
here.
valvula confinentis.
So what
Is it-
structure is
So
this?
they are it
Is it the pulmonary artery?
Okay, so
No,
this
is
is
this
the air
not?
in the
Pulmonary
transverse
artery will be
colon
very
or
big.
a splenic flexor.
If you look
Okay,
at
this is
again,
we talk about
because
recurrent laryngeal
we don't
nerve.
have
You see that?
problem to call
This is
pulmonary
the
artery
vagus
at all.
nerve on the left. It's
Okay.
coming down.
Pulmonary
and
artery
then
is here.
It curves around the AP window, and then it's going up, and then it's
lower.
supplying the vocal
Let me
cord
stop.
here.
I'm
For
talking
the
about
right,
the structure, the
recurrent
this person
laryngeal
does
nerve
not
is come
have
down
it.
to the
It's not
subclavian.
constant.
You see it sometime, you don't see it sometime,
and
but
then
if you
it's
see it
carotid.
and
It
then
can be
it's
big,
curvy
it
up,
can be
and then
small.
supply
Depends on
the
vocal
cord
obstruction
here.
or not.
So
So
this is
why
my pulmonary
postnate
artery. Have to scan the
Left
patient all the
practitioner
way
in
down
I guess.
to the AP window to rule out possible.
Okay, look
mass
at my choice.
in the mediastinum.
Did I say
Okay.
option here?
And can you tell me how many
This little
density
guy,
are we seeing on this chest
this guy.
radiograph? Okay, let's count it together. Okay. One,
And do
two,
I
three,
have the
four.
next
Okay.
one?
This density here,
Do we know what
very
structure
dark
is that?
looking.
It's the venous
A
structure.
here between the intercostal, in between the
talking
ribs.
about
This
that.
is intercostal space. This is the
And we're talking
density
about
of
this. See
air.
that?
So air
So
is
this
always,
it has a
always
nickname.
dark.
We call it
And
aortic
then
nipple.
B is the fat.
Have you heard about aortic
Follow me.
nipple
See
before?
that this little fat here, the fat line here.
I'm
So
sorry,
fat
is it like
a bit
the
loosened,
aortic
but not
knob,
as
or like
loosened
the
as air. So
arch of
two
aorta?
densities already.
Yes,
Three,
it's close. It's different structure.
this
It's
is
the
the
soft
aortic
tissue.
arch. This
But
is the
the
liver.
aortic nipple
And this is the spleen.
This little structure.
Okay,
The
look
soft
at the
tissue.
CT
This
here.
is soft tissue
Is the
here.
venous structure that is
This is
wrapping
fat.
around the
Fat
aorta.
plane is
the
here.
aortic,
So
three
aortic
density
arch here.
already.
And it will
Four,
cause a
the
little,
density of the bone. It looks a
nipple
bit dense.
adjacent to the
You can see
aortic
dense
arch.
here.
I think
This is bone. And
Intercostal veins, I
five,
guess.
the density of
Intercostal veins.
of
intercostal vein.
metallic here. Okay, so we have five density. Now we're gonna go into the fun part. This is option. So is this in
chest radiograph?
vein. So this is the left superior intercostal
This is
vein.
the one that
If you
is
hear the
abnormal,
name,
anyone
people
picks
call it
anything up
aortic nipple.
compared
So
to
we are
normal chest.
talking about the left superior intercostal vein, just in case that someone talk about
For
the
sure,
nipple.
the person on
And
the
when
left
you
is
look at chest
older because
radiograph,
look
keep
at
your
his
eye,
bone,
keep
really
observe
old
it.
looking,
Sometimes you
has
see it,
spur
sometimes
and
so big, sometimes it's so
scoliosis or
small.
either
So
spinal
if the patient has
curvature,
venous
and the
obstruction,
exposure is
it
a
will
bit
look
different
big
between
because
these
it's a
two.
path of
But
the
what is
parietal
abnormal? I'm going to
circulation.
say the patient come
But if
in
the
with,
patient does not have
a cough and
obstruction,
fever.
it may not be noticeable at all. Okay, so
The-
it's not
the right,
is the
chest,
vein. It's
radiogram
eventually
is
it's
the
draining
normal
into the
chest.
SVC.
The left is the
left
the one that is
superior intercostal
abnormal.
vein, or the nickname is aortic
Just
nipple.
a quick look compare
Okay,
these two.
what do we see
see the
on
difference.
chest radiographs?
Cardiomegaly.
Is this a normal chest? When you say cardiomegaly, we measure from the biggest diameter of the heart here to here compared to the internal diameter of the chest, which is from here to here. To me,
does it
just
look
by
normal to
eyeball,
you?
this is
The
the
patient
probably about
suppose even gonna
1/3
make
of the
thing up here.
cardiothoracic ratio.
The patient
So
came
he's okay.
just for annual checkup. Can he go home?
And this one is not big. This one is not big.
Annual
So
checkup,
when I
and then
clinical
this is
indication
his
is
radiograph.
important. So when I say cough and fever, you're looking for pneumonia.
No. No.
The pneumonia
Why
is
not?
happening in
Is that
the
you see pneumonia
air
or you
space
see
of the lung,
something?
which is those alveoli and the lung parenchyma. So we're looking for something like
edema
that.
by
Okay,
pulmonary.
I'm gonna this one
Edema,
is
pulmonary
here.
edema.
See
Okay.
behind the heart,
Very
it look a bit dense.
What else?
This one clean. The normal one is
Is
clean,
it lung
but
mass?
this patient is dense.
Mediastinal
Okay,
mass,
and we're not sure, so we
pneumonia,
look at
pulmonary
lateral.
edema,
So the lateral is not
or
normal.
metastatic.
There is
Check your
something
chest.
here above the diaphragm.
Yes, okay.
So this
Trachea
is
is shifting a little
an
bit, not right in the
example
middle.
of,
But remember, we talked about this yesterday.
left
the
lower
trachea
lobe
can shift
pneumonia. Okay.
because you are we getting older or you are baby.
All right. I'm showing you
With different
next
reasons.
one. This is our patient. And actually, when you are here in the United States, they don't even tell
What
is
else?
the clinical
Okay, let's go to
presentation.
do
They
this
just give you
together.
the chest
Start from
radiograph
the
and
heart.
then you have to read it.
The heart
You
looks
don't even
okay
know
to you?
what's going on with the patient,
big
which
heart?
is really important.
No.
Anyway,
Very
if
big.
I don't tell you anything
It's very
about
big.
this person,
So we are seeing like a
uh,
shadow coming down here, right?
Yeah.
right?
Okay, big
We
heart.
can tell.
What else?
This is the port.
Is it the
part is like
pulmonary
a venous
vasculature?
access.
Look like
So
pulmonary
we
edema
have
yesterday.
the part
Look
from
busy to you?
the
The
jugular
pulmonary
vein
vasculature will
coming
be very,
down
very
to the
prominent,
probably
in a
distal
pulmonary
SVC
edema.
or something
Do
here.
is it noticeable
SVC.
here?
So we
If
can
I
tell this
said it's
person
an
is
annual
sick.
checkup, means
Either
the patient
he
does
have
not have symptoms.
chronic or something that needs long-term antibiotics,
So
or he
not
has a
likely to be
cancer
pulmonary
that
edema.
that needs long-term chemotherapy.
Sometimes we
That's
can
why
make
here has
a
this
normal
port.
lung
The
looks like
port is
pulmonary
better
edema
than the
by
IV because it lasts
adjusting the
longer. Sometimes
exposure
lasts like 6
on
months
the-
or a
on
year
our
even.
workstation.
If you take care of it very
Easily.
well and it's not infected.
So
Okay,
no symptoms. So it's
what
no
do we
pulmonary
see in
edema.
this person?
Okay, big
compared
heart.
to normal chest.
Anything else? So trachea is shifting a little
Not
bit.
cardiomegaly, I still let go.
Mediastinum looks okay to you?
Yes, sir.
As in the
Okay, let's
stomach.
go back to the normal
In the
case.
stomach.
This is my
so
near
this one we
normal.
just can tell
Forget
this
about
person
this,
is in
the
upright
clinical
position.
here.
This
This
is my
good.
near normal.
This person is
normal
younger
air in the
and
stomach.
memorize this chest radiograph.
Okay.
I'm gonna
What
go
else
to
do we
the
see?
to this case.
Okay. All right, let's follow me. Okay. So these two
Okay,
look a
all
bit
right.
different.
Okay, so now
focus
trachea
on
is
the
shifting
right lung
and a big heart. Now we're gonna look at this.
and focus
I'm not
on
gonna
the
tell
right
you what it
lower
is.
lung.
You can tell me after you see CT.
Compare right lower lung on
Okay.
the left and on the right.
Okay, so you said big heart, right? Does the heart look really
Something
big to you
different.
here? Look big or not?
Density of air is different.
Good.
Normal
That is
or
very
normal
good.
heart
See that?
size or
This is
really
your
big
heart
heart
border.
here?
This is
Normal.
your heart border. And
Normal.
you're just seeing something
you are
weird
seeing
here.
fat.
Right?
See that?
So it's
The whole
almost
thing
like
is a
the
fat.
case before,
And if
but
I
instead
stop it
of
here,
the
this is the
left,
fat.
it's more on the right. I
It
think there's
is
something here too.
it fools
in the
you
left,
here.
So the
lung
heart
base
itself
is
is not so
big.
clean.
And
This is way
actually,
cleaner.
you can appreciate
This
the heart
no-
border is right
perfectly
here.
normal on the right, but this one
That
look a
is
bit
the left
funny on here too.
ventricular
So, but main thing
border.
is
This
here.
is the
So there's
pericardial fat.
some opacity
Okay,
in the
we are seeing
right
fat.
lower lobe.
Okay, and the
I can say
trachea is
it's right
shifting.
lower
Let's
lobe, not
look.
right
Let's
middle
look.
lobe, because
So
I
this
still
is
can see
again
heart
anatomy.
border.
Left ventricular
This is the right
outflow
middle
tract.
lobe.
This is
Right
the
middle lobe
aorta.
will be
This
in
is
the same
pulmonary
plane
artery.
as the heart border. So
Okay,
you
this
will
is the aorta,
the heart border
pulmonary
will
artery.
obscure.
Look at trachea.
But this
The
one we
trachea
can
is
well,
this is my
we can
trachea.
well delineate the right heart border. So this is in the right
It's
lower
shifting
lobe.
actually.
Okay.
Look at
I'm gonna
this
go
is shifting
to this
too.
one is the one
Why
that
is
is
it
abnormal.
shifting?
I'm going to go to lateral. So I'm looking for something in the right lower
Does
lobe.
this look
My
normal to
my
you?
right lower lobe is
Okay.
right here.
This is
And
my
this is abnormal because there's some density
aorta.
right here. So it's
We just follow
corresponding
it
to the
up.
PA, the frontal projection that I see.
then the
So I feel
aorta
so
is
confident
right
to call
here.
this again.
Right
It's
here.
the lower lobe pneumonia.
Okay.
But this is on the
Let
right.
me go back to the
Okay,
normal
this
case.
is the density in the lung.
I'm sorry that I
The,
did not put
lung
them
is just
all
look,
in the
you look for
same,
something
on
asymmetric.
the same image.
Look
Okay,
for
look
something
at my
asymmetric.
aorta
Normally
here.
it's symmetric on both sides. Okay, what
This
about
is my
this one?
aorta,
Compared to
aorta.
normal.
And then aorta is coming down here, nice looking. All right, now I'm gonna go to the case.
Is it too difficult here? I don't know what to prepare, but
Okay,
I think this is
look at my
well,
aorta
thing that we
again.
see every day. Tell me, is it too difficult so we can tone it down?
They look.
Or is it
they
too
look,
easy? We can tone it
are
up
they-
too.
Do they look
Okay,
alike?
let's finish this up. So what is the
Okay,
difference
all right,
from the
let's come
right and
back
the
here.
left?
This is the mediastinal mass.
The
And
right
this mediastinal mass is pushing the
No,
aorta
sir.
to the
No, sir.
left.
Left and right borders
And if
of
you
the
look
lung.
at it again,
left border of the
this is
lung.
aorta that is pushing.
Are you
was
talking
pushed
about this?
to the left.
Yeah,
And
left.
this is the thing that we think that is mediastinal
Right,
mass.
right,
And actually,
right.
is
Right
this
border
really
is not sharp.
mediastinal mass here?
Right border
What
of the
structure
lung.
is that?
Yes.
Okay, let me look. Are you
This
talking
guy.
about this area?
Famous. Right lateral border of lung.
Look at it again.
Right lateral
I'm gonna
border. Are you talking about
follow
here?
it with me?
I'm
from
sorry
the
because
beginning.
I'm not
Okay,
sure that
look at
we
this
are on
guy.
the same
Okay, let's
page.
start from here. I'm going to do here. Keep your eye on this structure. Okay, I'm
The
going
right
to
lung
go.
is normal.
Keep your eyes on it. Keep your eye on
The
it.
left
Keep
lung
your eye
is
on it.
normal.
What is this structure?
So now we are toning down to the mediastinum and the heart.
Okay, again, this guy, right, is the guy that is pushing the
Okay, is there
head
anything
here.
wrong? Compare the
then
heart on the left
follow me.
and the heart on the
What
right.
structure is that?
Heart,
Esophagus?
cardiomegaly.
Okay, the heart on the left look a little bit
Esophagus
bigger.
is
The
right
heart on the
here.
right looks
This
normal.
one is
What
esophagus.
else?
Thyroid tumor, I guess.
This one is aortic arch.
Look at my
The
stomach
patient has
Yes.
on the left
right-sided
and our
aortic
stomach on
arch
the right.
and
Does it
has
look right?
a lot of
No.
atherosclerotic disease.
No,
So
right?
it is
The
losing
stomach is
elasticity
not
and it's
like
really
here.
hard. So the
My
trachea
stomach is going
pushed
up into the
to
chest.
the left.
See
You can
that?
see that this is the
Yes.
mediastinal mass that turned out to be left
Not just
right-sided
that,
arch.
not
Normally
just that.
we don't have
Follow
right-sided.
me.
We have
Look
left
at the left heart border. See that?
the left
There's
aortic
air
arch, not
here.
right, not right
An
arch.
air here.
But this
and
person,
air
the aortic
in,
arch is on the right, and then it's pushing the
almost like
trachea
above
away.
the
It's
diaphragm,
look
and
like
also
it's
air
like
behind the
mediastinal
heart.
mass. Follow this guy.
So there's
You
something
can
wrong
follow
here
it to the heart.
in the mediastinum.
See that? It's coming down and connect here,
Pericardial
here, up here, and then look at it. See that? It's
Pericardial
coming
will be
up
difficult
here,
to see here.
and
This is
then it's going
pericardial. You can't see
right there.
on chest
and then
radiograph. You
coming
see it
down.
on CT.
Normally,
but
the
not on chest
aorta should
radiograph.
be on
Back
this
of the
side of the
body.
spine.
On the left, not on the right.
I did not hear you. I'm sorry. So this is an
Diaphragmatic
example
hernia.
of the
Diaphragmatic hernia, good.
right-sided
See
arch.
that? So we see all this air behind the
Are
heart.
we okay?
Air
Yes.
in the stomach.
Okay,
is not
all right,
in a
next
good
one.
place. And then
I'm
on
not
lateral
telling you
where it is,
anything.
can you
We
tell
just
me?
have this chest radiograph and then the CT of the same patient.
So we pick it up on
have the
PA here, and then on
patient
lateral is
information
behind the heart. Our heart
hidden
shadow
here.
is here,
Okay.
and this is it.
So is chest radiograph normal?
This is it. The whole thing here is going up into the chest. It's not stomach. So this is
Okay,
an
let's
example
do it
of
one by
hiatal
one.
hernia.
The right lung
Hiatal
for
hernia
you
has
looks
two
okay.
types. One is
Is
the
there any
sliding
pneumonia,
hernia.
any
Sliding hernia,
population,
the
any
ET
lung
junction
cancer,
is going above the
pneumothorax?
diaphragm. and the whole thing is going up. And then the paraesophageal hernia, the right lung only gastric now what about the left lung up in there? So this one, you don't have to specify on chest radiograph. We have a sliding hernia or paraesophageal hernia. You don't know. One I really can't because you cannot see the EG junction. The whole thing, so that one is on opacity everywhere. But on the chest radiograph, we just say hiatal hernia enlarged. And I can't see the heart. Okay, I have question. I don't know where the heart is. Maybe you somewhere in here in the left lung, and then the trachea is shifting. What is that? So this tells me something. And this actually, tells me you see it on here too. There is on the volume loss in the left. Metallic. So it is pulling everything to it. Is what lung volume loss? Either prior surgery, maybe lobectomy, pneumonectomy, or the patient has like so this is the location is the aorta. This is the left ventricular and then caused obstructive and atelectasis. This is lung volume loss, and then those atelectasis pulling the heart, pulling the left, pulling the trachea towards the left. This is the aortic what I can guess from here. There's still some lucency in the left lung. I'm not sure. Is there air in the left lung, or is there air in the right lung that caused the midline and try to replace that treatment? Okay, we don't open something wrong. We put it from this. We're gonna say there are evidences of deployed lung volume loss, severe lung volume loss on the left. But what's going on in there, we don't know. This one is a large mass. It could be pneumonia combination with pneumonia. It could be abnormal one. I don't know. Abnormal one. This is our. It's not comparable, but I still have to compare. This is our right lung. Side by side. How just for the start. Very so well expand. This person toward really the midline, cross the midline, and then going to supply. And this is we have the tracheostomy. And we don't see. We don't even see left lung here. A good breath. He's all gone. So that's all. And the heart is here. And we so the heart every day we will have the study like this. I think probably like almost 80% of cases. So this is like look at this. This is my midline, and the right lung is crossing 20% across the mid. This one will be easy, but the one that is really sick, and then this is my aorta. This is what do we see here? Okay, and we don't see left lung. Okay, let's look at the airway. This is our trachea, maybe. This is our carina. Lateral sulcus. We're going to focus on the left lung. Claustrophoenic sulcus here still okay. Maybe a little bit on the left. The left main bronchus cut off, and everything what is else? Gone. One of you asked about esophagus. This one is the air in the esophagus. Coronary angiography. It's not in the trachea. Trachea is coronary angiography, but this is the air in the esophagus. So this is an example of pneumonectomy. So after we did pneumonectomy, eventually the whole thing will be gone. There's no more left lung, and you can see the bronchial stump. A big air here, because here, right? So this is our diaphragm, and then it's cut off. This is our diaphragm. This is an example of and then there is the air underneath the diaphragm in the belly. And the usual post-op. Left pneumonectomy. Okay. What we call it? Okay, I'm going to show you a few more cases, and then we will. We call the intraperitoneal. This one I showed you yesterday. We have this case yesterday, but I did not show you the CT. So we see a big mass. Pneumoperitoneum. So this person has a big pneumoperitoneum. Okay, here's this. If you are reading the study on the left here, and this here, big, huge mass in the right. You see big pneumoperitoneum. Okay, let's look at this on air, CT. Free air in the belly. Very heterogeneous enhancement, big mass. I have only one that is here emergency. A coronal, and then you on cannot axial, just leave it alone. You gotta do big, something. Big, so what should we do? Not the whole thing is the mass. Before calling the clinician, big mass, but because there is a list of things that is emergency, and residents have to call clinician. A small from the L, and this is one of them. And this is before we call the clinician. This is a big right upper lobe mass. We may not have to call this. Is the superior vena cava. It was pushed This person
we
can
should
has
look into the
SVC
medical
obstruction
record.
easily, but at
Does
the
the
moment
patient,
there's no SVC
did the patient
obstruction
have
yet.
recent
It's still
abdominal
patent.
surgery?
So this is lung cancer.
Or like a peg tube,
adenocarcinoma. This is a lung
GI,
cancer.
the feeding
Alright.
tube in place in the stomach.
That one
like a peg tube,
I showed you because
percutaneous
we have it
gastrostomy
yesterday.
tube, or
Okay, what
jejunostomy
about
tube
this
placement.
one?
Recently,
PAs
like
is
in a
normal?
day, 2 days, or even a week. Actually, should not be
Look
a
symmetric.
week.
Everything
The
looks
air
perfect here.
can
There's nothing
introduced by the
there.
procedure
Okay.
and the surgery.
What about
If we do
lateral?
just peg tube, percutaneous gastrostomy, or percutaneous jejunostomy tube placed in
anyone
here,
pick up
you are
anything? I think
allowed
this
to
one
have
may be a
free
little bit
air,
too
not a
difficult
lot,
because it's
a
very
little bit,
subtle.
about
On the
like
PAs
1
look
to 2
perfect.
days, it
It
should
looks
be
normal.
gone.
But the lateral
Once,
is not.
like
There
a
is
week
soft
after
tissue
peg tube
density
placement,
right here
you is still
above the
leaking. You still see air.
diaphragm.
That's not normal.
So that is
Something
kind
is
of
leaking.
soft
Okay,
tissue
but
density,
if the big
which we don't see
abdominal
is on the
surgery,
PA. If
you
I
can
were
have
to
that
read this
air
case,
maybe like for a week,
and I don't have
and
prior
you should
study,
not have it
and I know
after
nothing
that.
about the
If you have
patient,
the
I
air
will say,
in
I see
the
something
period
here.
that you don't expect to see it.
I don't know what it
abnormal.
is.
Or
If the patient comes in
if
with
this
fever,
person
with
does not
cough,
have
this may
any
be
history of
pneumonia.
surgery,
If the patient
what
does
can
not
it
have
be?
symptom and if he's old and he's a smoker, that may be cancer, which I cannot appreciate that on the PA.
I would say, okay, we already look at the
if this person have
medical
infectious
record,
symptom
no
at the
history
beginning,
of
I would
any
say
surgery,
likely
any kind of
pneumonia.
surgery, and to
Treat the
big tear
patient,
in the
come
belly
back
here.
and repeat chest
It's
radiograph.
leaking from everywhere.
I would say
Yes,
that. But if the patient is old,
So
I'm
it's
gonna ask for
perforation
CT.
from the GI
See,
tract.
the decision making is different to
Right.
the clinical context. So
Either
one of my
duodenal
senior
ulcer
colleagues used to
perforation,
ask
gastric
residents,
ulcer perforation, or even
what
sometimes
are
colon
the
cancer
three
can
most
have perforation, or the
important
verticulitis that has
things that you
perforation.
need to do
So
when
something
you do
is
chest
leaking from the
radiograph?
GI tract. So if this
He always
case,
say,
you look back into the history, after you
patient
have the
history.
history of prior procedure or
Prior
recent
study.
surgery,
Patient
forget
history,
about it,
prior
it's
study,
expected.
patient history,
But
and prior
if there
study.
is no
That
history of
his
those
answer.
surgery or
So all
procedure,
three
you
things
may
that
have
he's
to,
saying
you
is
need
just
to call the
patient
clinician
history
and do
and
discussion.
prior study. So those are
They
very
probably
important.
need to do something because this is not normal.
But in the United States,
Okay,
you
this
don't
is the
get a good,
emergency
you
one.
don't get an accurate clinical
air
history.
in the
There's
belly.
it's just bad.
I show you a
You have to
big
dig
one.
it by
There's a
your own
little
and assume
trace
what are you
one.
looking for
I did
sometimes.
not have
So
that. I
in
think not
conclusion,
that's
this person
obvious, so
has
I try to show
a
you
soft
something
tissue
obvious.
density
Okay.
in the retrocardiac
Compare
region. We see it on
normal
lateral projection.
on
We
the
don't see
right
it
and
here.
abnormal
So
on the left.
is this structure? You can tell me what it is.
I'm going to tell you history of trauma.
When I say trauma,
Okay,
I'm going to show
we
you
are looking
lateral.
for traumatic
It is
injury,
structure.
like pneumothorax.
What is that?
Fracture,
This in
pulmonary contusion,
this in thoracic aorta.
aspiration. This aorta.
Mediastinal
Don't forget, we have this is
hematoma.
contrast enhancement. So the vascular structure has
Or some
hemorrhage. So what do we see here? Density. This structure is outside the aorta, and is one of us say it's a stomach. Yes, it is.
Esophagus.
Okay.
Yes. The heart
Is
looks
the
big or not?
hernia, so it's not esophagus.
The patient did
So
not.
this one is a big sliding
So
hernia.
the lung volume is
the
not big.
EG
Everything
junction is
looks a
above
little bit
the diaphragm,
prominent.
and then the
Pulmonary
stomach is
vasculature may be a little
is
bit
up
prominent. The heart
above the
doesn't look
diaphragm.
so big.
This is the
Do
stomach.
we see
Rugi.
pneumothorax here?
So this the whole thing is the stomach.
I haven't shown you pneumothorax.
So this
yet.
is an example of hiatal hernia that you can see. Oh, it's always sit here. Sometimes it's so big and it's
So do we see
covering
any
the
traumatic
spine. So this
injury
is
in
the same
here?
person,
On the
and the
chest
study was
radiograph.
done not so long apart.
Who
Sometimes
picks
you
it up?
see
I'm
it,
gonna,
sometimes you don't see it.
approach
Depends on
three
it's
times.
lighting at the time when we do the chest
It's
radiograph
there,
or
it's
not.
there.
So
We
it
see
will
it
not be there
actually.
all the time unless it's really really big. The small
Is it
one can
mark
move
on
up and down,
clavicles?
but the
Yes.
big one it will
Yes,
always
you're
there.
good. See that?
Like this one is
This
pretty
little
big. This one is
fracture.
an example of hiatal hernia. And
Right?
good
It's
that
not
you pick up
displaced
the stomach
fractures of the
rugi. This
clavicle.
is the stomach.
And if you look at
Yes.
it carefully, compare the soft tissue
Okay,
and
next one.
the fracture site. It looks swollen compared to the right clavicle. That's
I am
normal.
sorry.
This is the fat plane.
This one is very subtle.
This looks a little
We're
dense,
not
so
going
it
to see
must have
anything on chest
hematoma
radiograph. If
close to it.
this is there is a little
as I tell
opacity
you
here
earlier,
in the
we are
left
responsible
upper
for
lobe here,
everything
which
on the
on
chest
CT
radiograph.
it looks bad, right?
Everything. So this one is the
This is a lung window,
non-displaced
coronal reformat
left
image
clavicular
of CT
fracture
scan.
with soft
This
tissue
person has
swelling
a
or hematoma.
lobulated, spiculated right upper lobe mass.
That one is
here,
fracture
maybe
clavicle.
about like 3 centimeter. By
All
3
right, what about
centimeter.
this one?
This background, there is a little.
We have
holes
a
in
few
the
more
lung
and then we're
here,
done
so
for
the
today.
patient
And
is
we
a
see
smoker.
tomorrow I'm going to show you
this
CT.
is an
CT
example
and
of lung
CR
cancer. And I
comparison.
want to show you.
See, when I
how
say
much-
CR, I'm talking
how
about
many
chest
we miss
radiograph. Okay.
on
So
chest
this
radiograph.
person,
compared to
I
normal.
don't know about this case
Okay,
that
the
we
left
missed
lung is
this or
normal.
not,
Abnormal
but
is the
I
right
haven't
lung.
looked at the history. But
What is
I'm going to show
abnormal
you
here?
how subtle
We have
lung
chest
cancer
tube
can be.
placement.
Okay,
Just
chest
that
tube is here.
and become
Normally,
this,
is
bad looking on CT.
why we put chest tube in there?
This is a
you
left
have
upper
to ask
lobe
me back.
adenocarcinoma.
Okay, what is the purpose of this chest
So,
tube? If you want to drain the
for
air
for the
or the
smoker, if we
pneumothorax,
see something
the
that
tip
we're
should
really
be
not sure,
in the
we
apex.
always ask for
If you want to
CT
drain the
because
fluid,
we have
the
no
tip should
idea.
be in the
It
lung
can be
base.
lung cancer
So it is
easily,
different.
and we miss a lot
Right.
on chest.
So the chest tube does
radiograph.
not have to
That's
be
why,
always
in the
apex
United
or
States we
always
have
at
lung
lung
cancer
base. It
screening
depends on the
program
purpose
for the smoker.
of putting it in. Why? Okay,
This
one
is
is
for
a young
the,
person with fever,
pneumothorax.
so there's draining air out of the chest. So what else do we see here? The left lung
I
is
think
not,
it's a
the right lung is
lobular
not, it's hazy.
consolidation, like
here,
pneumonia,
some like
maybe.
a haziness.
Okay, where
a
exactly it
little
is, you
bit
think?
prominence, pulmonary
I
vasculature.
think
Actually,
it's
see effusion here?
right
Little
upper
effusion.
lobe.
This is normal.
Right upper
See
lobe.
that?
Okay.
The right,
Right.
nice
So we
and
can
sharp
see
looking
this
here.
feature.
This one
This is the
not.
minor
the fluid
feature.
is piling up here.
So
in
below the
lung
minor
base,
feature is a right middle
piling
lobe.
up. Probably some
So is it the right upper lobe or the right middle
atelectasis or
lobe, you think?
aspiration here in the lung base as well. Okay, I'm gonna ask you.
Of course.
Oh, now
What
now,
is
now I'm
this
not sure
structure?
at all.
Okay, look at lateral. Where it may help. It may help. Okay, I forgot to tell
structure.
you.
It's
So when we
I
do
should
chest
not say
radiograph
structure
here,
because
we
this is
will
not
have
structure.
two
Is
more
this
post-processing
Respiration
image.
foreign bodies.
This is the routine. A
mass?
lung air that we normally see. We will see subtraction that we will subtract the bones out. And another subtraction that we will subtract
Solid
the
mass.
lung out. See only bone.
Okay.
So
It
we
could be a
will
mass.
What
One
if I
shot
say
of the
yesterday
study
we
is not
processed two more images, so we will get 3 images from one shot,
Collapse
and then this is her lateral. His lateral chest radiograph. This was not there
So,
yesterday.
we
It
are
just
seeing
happened
here,
this
is
guy just
our
happened.
feature.
We see it today, but not yesterday.
Our minor feature.
And this is the thing. The whole thing has the opacity or consolidation.
So it's something so quick.
You are, I'm fooling
first
you.
thing first,
because the
it's not a
extension
mass.
of the upper lobe
Or
itself
not a
is
lung
not
cancer.
just that. Because on
Because
lateral you can
those
see that
won't
how
happen
far
within
it can
one
go.
day.
So this is something that's really happens so quick. This is on CT. See that? As the patient has
this is
fluid
my
in the
feature.
lung, in the right lung, this is my minor
feature.
And on CT lateral,
The minor
this
feature,
is your
this is my
device,
feature.
So the
Right
whole
upper
thing
lobe
is at
from
the
the
right
is
in
in
the
the
right
lobe,
upper lobe.
and
You're
then this
right
is
at
my
the
right
beginning,
upper lobe.
but
And
because
go
when we
back
do
and look
chest
at this
radiograph,
lesion
the
again,
beam is coming
you can
from the
see I did
front.
not make a
So that's why
did
you
not
are seeing
magnify
part of
it
the
has
inferior
pretty
part
well
of the
defined border
right
with the
upper
lung,
lobe. That is
well-defined border with the
overlapping with
lung,
the right
and
middle
it
lobe.
should not be in the lung parenchyma.
Okay.
It
You're
should be
correct at the
something
beginning.
outside
And
the lung
normally,
parenchyma. Lesion in the
pneumonia, the
lung,
usual
normally
pneumonia,
the border is not so
we call it lobar
well
pneumonia.
defined.
So
But
it
if
will
you see
confine
well-defined
to
border,
one
it's
lobe
probably
only.
something
It
in
will
the
not cross the
pleura
fissure
or in the
and
chest
go
wall.
to the next lobe.
Okay.
Because there's no
This
connection.
one,
Fissure
we call
is a
it
national barrier
pseudo-tumor.
between lobes.
Because
Once you
it's
get
just
trouble in one lobe,
it
it
looks
will
like
stop.
tumor, but it's
It's almost
not.
like a
And
big,
actually, it's the loculated
a
fluid
big barrier
in the
between
major
two lobes. So
fissure
the
of the
infection
lung.
will not
We
cross
can tell that
fissure.
because the patient already has pleural fluid
That is in
everywhere
general.
else.
I'm
So
talking
it's
about
just
the lobar
seeping into the
pneumonia.
fissure.
Sometimes
and
if you have aspiration
decided
or
to sit there
bronchopneumonia,
for a
it will
long
cross
time.
the fissure.
So it's formed
And
a
that is an
pseudo-tumor
exception
like
as well.
here.
If the
So
fissure
every mass
is
like
complete
lesion you
fissure,
see
the
in
whole
lung,
thing
not
is
always
separate.
a lung,
Upper and middle lobe is
a lung
separate.
lesion.
So
It can be
it will
pseudo-tumor.
prevent the infection spreading.
Can it
And
be
if
any
the
structure?
fissure is
Yes.
incomplete, The
Any
infection
questions
will
here?
cross that fissure and go to the right
Can
middle.
it be any subcutaneous mass
So it
as
depends
well?
on the national
Oh yeah,
barrier
it can
of that
be.
person.
It really can
It
be
has complete
subcutaneous
fissure
mass
or
in the
incomplete
anterior
fissure.
chest wall.
So this
The
one
thing
is
it
example
happens so
of
quick.
a young person. This is a right upper lobe
Right?
pneumonia.
And if it's
And,
subcutaneous mass in the chest
if
wall, you
I
see
were
it
to
at the
read this
beginning.
case from this,
The clinician
and
knew
suppose this
about
is
it.
25
And we
years
have a
old
case of
person,
the
his bone
neurofibromatosis.
doesn't look so bad.
It's everywhere.
So he's young.
It's not just
so
in
I
the
will say,
lung, it's
okay,
on
I'm
top
thinking
of the
this is
chest
the
wall,
right
so
upper
you
lobe
can see
pneumonia, and I will
lung
stop.
nodules, and you also
I just say that, okay,
substitute
go back,
nodules.
treat the
That
patient
is
with antibiotics.
neurofibromatosis.
And if the symptom is getting better,
this one
you do
will,
nothing else.
yes, very
Done.
well be.
If the
can be in
symptom
chest
is
wall.
still there
The
after
timing
you
is
expect the
timing
patient
is
to
important
get better,
to tell you
or the
what
patient
it
is
can
getting
be.
worse, still in the symptom, come
easy
back and do
physical
CT.
exam. If you see
If
the
this
mass
is
in the
an
soft tissue,
65
okay,
years
is it really
old
mass?
man,
Just give the
and
clinician
is
a call and
smoker,
ask. I do
will
that all the
say,
time.
I'm
Okay,
not sure.
is there
This
anything
is
here?
pneumonia
They say
or
no.
this is
Okay.
lung cancer
That just
and
cut
hiding
out
in the
one of the
pneumonia
differential
because
diagnosis.
they can coexist. So in
Okay,
the
what about
elderly,
this
I will
one?
say, okay, I see
Okay.
here
Compared
it's
to
likely
a
pneumonia.
normal?
Suppose 65 years old come in with
Big
no
heart.
symptoms.
This one has
no
a big
symptoms
heart.
at all. This is definitely cancer. 65 years old smoker come in with symptoms. This can be pneumonia, can
Looks
be
so
cancer.
busy.
So in that
Look
case,
at
I
the
would
right,
say go back to the
chest
patient
radiograph.
and come back
It's
to
so
chest
nice and
radiograph
crisp.
again. If the chest
Look at the
radiograph is
left.
better,
This looks so busy.
I'm not satisfied.
So big
he has
heart
to come back
may
until
have
it's gone.
like a little bit of
And,
pulmonary edema.
And if chest
Because it's
radiograph
all
after
look
the
like
treatment, symptom
busy
is getting
everywhere,
better, but the
pulmonary
chest
vasculature
radiograph
look a
look
bit
bad.
prominent here and there.
It
It's
still look
everywhere.
really bad. Or
Okay,
look
we
even
leave
worse,
that alone.
I will ask to do CT.
We leave mediastinum
See,
alone.
Now
Now we look
our
at soft
decision and
tissue and
recommendation
bones.
is based on the clinical context.
Is it normal?
Always.
Are they normal? Soft tissue and bone?
Different age group, different management, and different recommendation. Okay, this is the right upper lobe lobar pneumonia. Okay, I think this is the last one for today.
Okay. The
What do
bone
we
is not
see? This
normal.
person is
this one is
pretty
really
sick.
like eye-catching here.
Because
Because the
this
bone
is
is look a little bit dense.
It
It
look
look
very
very
dense here. And this is
compared
the
to the
NG
normal
tube.
bone
We don't see
on
the
the-
whole
on the
thing,
right.
but this is the
This
NG
one looks
tube
dense,
and ET
looks
tube.
dense.
ET
It
tube looks
feels-
good because this is the
and this is a man.
carina, and
It
this is the right
feels
upper lobe bronchus
sclerosis
intermedius, left main
of the
bronchus.
osseous structures in
Don't mind,
elderly
there's some
man.
like
Now, what are we
bibasilar
thinking
retrocardiac
here?
atelectasis and a little bit effusion. What else do we see? What can cause diffuse sclerosis of osseous structures? The heart looks big or not? The heart looks okay, not
Something
big.
systemic.
Okay,
because all
we're not
bones
going to pay
affected.
attention to the heart.
All
The
bones
lung, we
here,
already
every
talk
single
about
piece
it.
of the
Pleural
bone,
effusion, we
including
already
spine.
talk
I did
about
not
it.
show you. I
Now
saw
we talk
CT
about
of this person,
mediastinum,
but I did not bring that up because today we're talking chest radiograph. So I did not
Looks
bring
normal
that
to
up.
you. So when you see that, the few things to think about is systemic disease. What's systemic?
I
It's
think I
maybe
can see a
metabolic.
really big, maybe a mass on the
Metabolic
upper side
disease
of
like
the,
a renal
like in the center.
failure,
Yes.
a chronic
So there
renal
is a
disease, and
big
then
mass.
have
When the mass is big,
diffuse
we have
sclerosis,
no idea where it's coming from.
hyperparathyroidism.
When the mass
a
is
lot
the
of
medium
calcium in
size,
the
that's the
blood,
best way. That's the best time to
chronic
tell
renal
where the mass
disease can
coming
have
from.
that look
This
easily.
one I have
And
no
one
idea.
more thing you think about.
If we don't see
have
the
to think
patient, we
about
just say, oh,
metastatic
big,
disease.
either
Okay.
this
mass
person
in the
has
neck
prostate
itself, like
cancer.
soft tissue
This is
outside,
prostate
or
cancer
mass in
with
the
diffuse bone
mediastinum because it's just so
metastasis.
big now. We
So in a
cannot
man,
tell.
we think when we
Okay,
see
let's look
sclerotic
at the
lesions,
CT.
we're thinking about few things: lung cancer and
The vessel
prostate
is
cancer.
displaced. This is my
If this
trach,
is in
my
a woman, we're thinking
ET
about
tube
two
is
diseases:
here.
breast
So there's
cancer
a
and lung
big
cancer.
heterogeneously enhanced necrotic
Okay. This person,
mass, diffuse sclerosis of the
supremediastinal
bones
mass.
here
I'm
is
not. I did not
because
do the
of chronic
movie
renal
for you.
disease.
Did not
It's
get
because
the
of
movie in.
he's having
But this is
prostate
a
cancer with
thyroid
metastasis.
cancer. Thyroid
Okay,
cancer does not have
this
to
one
be a
is
big mass.
easy.
This can be smaller than this, but produce a lot of symptom and abnormal
Right
thyroid
and left.
function test.
You see
So
obvious
the thing is
abnormalities here. Do we
when
see
you
it?
see trachea deviation, don't forget to think about the thyroid mass as well. That the upper trachea, and this one is a big mass. It's not
Anyone
deviate
see
a lot
anything
like
on
see
the
here.
left?
Still,
This
So
is
there
the
is tracheal
spinous
deviation on the
process.
right
See that?
side and continuous
Normally,
opacity
this
on right upper side.
tracheal air column should be right in the middle.
Good.
So we see a big
So
mass
it's
here.
pushed
Okay, let's
away.
see that?
Tracheal air
The
column
whole
to
thing
the right.
occupy the whole
So
thing
it's a
in
big
the
mass,
right
extrinsic
right
pressure
upper lobe,
effect to the
right
trachea here.
paratracheal,
Right
so an
tracheobronchial
example of
to
upper hilum
thyroid
here,
mass and
and this
thyroid
one is
cancer.
normal. This one you should see
I think that's it
nice
for
and thin
today.
looking paratracheal
I am on
stripe
time,
like that,
1 hour.
not a big mass like this. So this is definitely a lung cancer. And a cancer, I should not be definitely a lung cancer. You have to look at it on chest radiograph. It's lateral wall, on the lateral view is here, And this is right upper lobe mass, is adenocarcinoma. Okay, it's not, when we see right upper lobe mass, we have you heard about the golden S sign? I can find that for you, but not today. The golden S sign is the mass in the right upper lobe and obstructed the right upper lobe bronchus and then cause collapse of the right upper lobe. So it caused like a S shape, right upper lobe opacification. This is not golden S. But that is a classic for the golden A's. What about this one? Abnormal compared to
Cardiomegaly.
AMI. Oh, don't be so confident. Sometimes it may not. It may be just volume overload. Yes, that is one common cause. When we read chest radiograph, we don't go like into the detail like that. If you really want to do that, you have to dig into the medical record carefully and say that in your report. But I don't do that because we read 200 chest radiograph per day. We cannot do that. We have to go quick. So we normally say, okay, likely this. But the cost, you gotta go find it. I don't know what it is. So the heart is big, very big. This is cardiomegaly. When you see big heart, it could be just the heart is really, really dilated. The chambers are really, really dilated. Or the patient may have pericardial effusion. Right. So this one, normally pericardial effusion, it will look like a fast like shape. This one doesn't look like pericardial effusion. Just if there is any, gonna be very little. But big heart, look at pulmonary vasculature. Look at here, my hilum, and close up. Look at it carefully here. If you can magnify it, I cannot do it from here. See how busy this vessel is. And look at the upper lobe vessel is big. Lower lobe vessel is big. They're all big. But look at this upper lobe vessel on in normal person, it's not big. It looks nice and clean. So, and if you go a little bit down here, you see these little lines, little line. That is curly V lines, which indicate interstitial pulmonary edema. So this person has a pulmonary edema, and this is the lateral costophrenic sulcus. Still look okay here. However, look at the posterior sulcus. It's not okay. It's blunting. So this person has volume overload, probably cardiac dysfunction, impaired cardiac function, pulmonary edema, and trace bilateral pleural effusion. But the cause, what it can be, yes, MI can be one cause. The patient may have chronic renal disease and did not get hemodialysis and then had volume overload. That is another cause too. So there are so many causes of pulmonary edema. You can give some your opinion on the report, but I just don't. I just say pulmonary edema probably impact cardiac function, correlate clinically. Okay, and then trace effusion. What about this case? Okay, let's look at this. This is an interesting chest radiograph here.
So there is the cardiac shadow is enlarged. The whole cardiac.
This one, are you talking about this one, right? The new one, right?
Yes. I think this is suggestive of pericardial effusion, the Watermark sign.
This one has pericardial effusion or not? This one I am not sure. Normally, if it's not slam dunk, we can't see it. On chest radiograph, you see it better on CT And normally, let me show you tomorrow how the pericardial effusion on chest radiograph look like. Okay, I will find a case and then we show it to you tomorrow. Okay, that's for now. If we see this study on the on your here, I'm gonna say cardiomegaly. When I say cardiomegaly, I say enlarged cardiac shadow or cardiac silhouette. I don't say cardiomegaly because for me, the word enlarged cardiac silhouette can be one really, really big dilated chambers, or two, something else like a effusion. So it means both. I normally say enlarged cardiac silhouette or cardiac silhouette. I just say that, but I don't say. You can say, people say a lot say cardiomegaly. They use it interchangeably, but for me, it's just for me. It's your preference, but the clinician understand. And if we really highly concerned for pericardial effusion, we say we add something after that. So let's say easy one here, cardiomegaly. What else? Okay, look at this. Look at this. Look at my median sotomy. Look at my sternal wires. See that? All line up nicely. The patient has surgery. And look at this. These little clips here, see that? Little clips here right at the bottom of the heart. We can tell that the patient has bypass graft surgery and using the internal mammary graft as a bypass graft. Okay, that means this patient has ischemic heart disease, very bad one, already got bypassed. Okay, what else? Everything else looks normal beside big heart compared to normal one.
So there is a pneumothorax. I think so. Pneumothorax.
Okay, pneumothorax. Are you thinking here or here or where? No pneumothorax,
So
this one. Okay,
right upper zone.
The internet is a little bit slow. I cannot hear you. Please repeat that to me. Okay. All right. Beside big heart, probably calcified hilar nodes here on the left. Okay. And doesn't look like anything much. Some people will say normal.
Heart goes upward a little.
Are we talking about this heart?
Yes, left.
Okay. I show you one more image. This person just a few hours later. Let's look at him. Now, obvious. At the beginning, may look a bit big heart, but otherwise there's nothing really acute or bad. But after that, a few hours, look at him, same person. So what's happening? He start having heart failure here, start having pulmonary edema, and now it's more obvious. You can see all of the vessel is really prominent, and the heart is way bigger. It's not way bigger, it's a little bit bigger. So the patient start having pulmonary edema on this study, and a few hours develop a bad pulmonary edema. So sometimes you are like this one, I think about 50% of us will read it as a normal, but actually it's not. If we have a follow-up study, he just started to have that, and then he's sick now. So this is another example of interstitial pulmonary edema. So when we have pulmonary edema, the heart does not have to be big because you have non-cardiogenic pulmonary edema, right? Has not have to be big, but the pulmonary vasculature will change over time. First
from the redistribution of primary vasculature. Normally, the lower lobe vessel will be bigger than the upper lobe vessel. Now, if the upper lobe vessel is as the same size as the lower lobe vessel, we call that redistribution of primary vasculatures, which is the early sign of primary edema. And after that, it will the fluid will go into the lymphatic system and venous system here. It will cause a coarsening and a prominent interstitium. We call that alveolar edema. Once the fluid is enough, it will go into the air space. We call it alveolar edema. So there is redistribution of primary vasculatures, interstitial primary edema, and alveolar edema. Its step up of primary capillary wedge pressure will increase over time. If I am right, you have to check on me. I believe it is from 12. Let me think. 22, 17, 12 to 17, 17 to 22, and 22 up. The distribution, interstitial edema, and alveolar edema, millimeter mercury primary capillary wedge pressure. That is from the Swan Gang catheter that we put in. We measure it from there. Okay, what about this? Now, I'm trying to make it as big as I can to point this out to you. Oh, this is very nice. You see this my trach here, and why my trach here is pushing this one? It should be right in the middle. This one is not. Why is this pushed to the right? Anyone can tell? Should be right in the middle. Is that a mass here in the mediastinum?
The right lung. Sorry, left lung.
So it can be mass in the upper mediastinum or can be due to aortic aneurysm.
Yes. Okay. Mass in the mediastinum. Good. So normally it should be like straight down. If I go back to the normal case that we have, let me look. See that? It should be straight like that. Right? But this one is not. This one is curved a little bit. It's the deviation of the trachea to the right because there is a big aortic arch here. And when we get older, the vessel it starts losing elasticity, so it will like something really hard pushing the trachea. So in a baby and in an elderly, the trachea can shift toward the right because of in the baby the trachea is so floppy. Relatively compare the floppiness of the trachea and the aorta is harder. So that's why the baby, when the baby is in exhalation, the trachea will move toward the right. So that is considered normal. But in young people like you should be right straight in the middle. But when we get older, you're gonna shift to the right again because of the aortic arch. Is harder than the when we were younger. So that's because of the aortic arch. Okay, this is my right main bronchus here. This is my left main bronchus. You see the distance. Left main bronchus is so long. Right main bronchus is not so long. And this is the right upper lobe bronchus here. This is the bronchus intermedius. Very nice anatomy. This is the left main bronchus. This is left upper lobe bronchus. This is left lower lobe bronchus. Okay. Okay, that is our anatomy. Bad a calcified aortic knob and big aortic arch here. Okay, behind the heart looks bad too. The lung everything looks bad here. We have chest tube. We have chest tube here. Okay, one thing about chest tube you have to look at. You have to look at the side port. The side port is here, right there. Should be in the chest. Should not be out of the chest wall. If it's out of the chest wall, that won't work. That chest tube won't work. This one should work well here. Okay, all right. Let's look at the abnormalities here. What is lung is bad? That's one abnormality I want you all to pick up because this is critical. Anyone can tell me? Okay, let me, this is my right lung. Look at my left lung. See that? This is my left lung.
and this is air. So the air in the left lung, he has chest tube here. Chest tube is trying to drain this air. So this is the pneumothorax. Okay, this is an example. Is this obvious? Because I have a little pneumothorax. It doesn't pan out very well, so I choose the big one here. So whenever you see the pleural line, and this is a lung that is a little bit collapsed, and this is the air in the pleural cavity here. So this is an example of left pneumothorax. If this is not a trauma or the patient does not have chest tube in place, you have to give the clinician a call, because it can expand and then it can cause cardiac tamponade. The clinician should know about it if this is unexpected. But this one we don't need to call, because the chest tube look like it's functioned well here. The side port is good and it's already in place. The clinician will do nothing. They may, if this pneumothorax is bigger than yesterday, they may adjust the chest tube a little bit. That's it. That's all that they're gonna do. So we did not make a phone call here because it's expected in the chest tube that is in place. And look at this. See that? You don't see any pleural line here, but you do see it here. So that is the place that you look for pneumothorax. You look for pleural line. Okay, this one is another one. Very, very sick person. Big heart. And behind the heart, there's a lot of opacity behind the heart. This is the last case for today. A lot of opacity behind the heart, not just that. Opacity everywhere. This is air space disease. You see the air bronchogram here. This is the airways. This is the airways. We call that consolidation. The whole area, we call it consolidation. Okay, what else? The patient is so sick, has the ET tube placement, has the esophageal probe here in the cervical esophagus, has the NG tube placement, has a left IJ catheter placement, right IJ catheter placement, and also have the left chest tube placement. The side, the tip of the chest tube is in the lung bed, so they're trying to drain fluid, and then the side part is still good. There's a lot of subcutaneous emphysema here. I know the study is bad. I cannot make adjustment because the resolution of this laptop is not as great as the PACS. The PACS has a very high resolution. You see it very clear, but this one may not. But there's something else in the, don't mind about all of this consolidation. Look at the left lung and tell me what is wrong beside all of those consolidation. The patient is lying down in the bed because he's so sick. The chest radiograph was taken when the patient is lying down on the supine position. I want to show you this. Okay, let's look at this one is pneumothorax. Okay, look at this. Normally, it should not go that deep. This one is way deep down into the lateral sulcus, lateral costophrenic sulcus here. So it's way deep here. When the patient is lying down sometime and has pneumothorax, sometime we don't see this. We don't see that because they're lying down, so everything is going up, but the air will go down into the lateral sulcus and sit there because of the position. So in a supine position, you may not see apical pneumothorax, but instead of apical pneumothorax, you will see this. We call this deep sulcus sign. So it indicates the patient is having pneumothorax, and we are taking a picture when the patient is in supine position. So we don't expect to see the usual apical pneumo in a sick patient. So we're looking for deep sulcus sign. But for this case, doesn't matter. He has the chest tube drain here, may not work well for this pneumothorax, but the chest tube is in there, somehow is draining. So all of this consolidation here, it could be a lot of things. It could be multifocal pneumonia. It could be ARDS. It could be pulmonary hemorrhage. It could be pulmonary edema. Could be a lot of things. Depends on the clinical context. If this patient has high white cell count, I will go by bad pneumonia. If the patient has normal white cell count, and I'll go by a pulmonary edema. And if the patient has hemoptysis, I'll go by pulmonary hemorrhage. So it depends on the clinical context. Once you have this look, it can be anything. We can't tell. So this one is an example. Okay, I think that's all for today. I'm